Hi, welcome everyone. I'm Beth Tinker. Just going to wait about a minute for folks to join, but thank you for being here. I see the number still ticking up. Maybe just 30 more seconds. Okay, let's get started, everybody. Welcome. Thank you for joining us. Healthcare Authority is really pleased that you made time for this and eager to share with you our current work and objectives around our maternal care model. Next slide, please. So my name is Beth Tinker. I am a clinical nurse consultant at the Healthcare Authority. I work in our clinical quality and care transformation division. And again, it's my pleasure to be here. And we hope that this will be a dialogue. We're going to present information, and then we really truly do hope to hear from you all, your thoughts and reactions and reflections. So thank you for joining us, and I will turn it over to Mary.
Yes, hello everyone. Echoing Beth's appreciation, it is great to have you here with us today. We are very excited about this work. My name is Mary Fliss. I'm the Deputy for Clinical Strategy and Operations here in the Healthcare Authority's Clinical Division. And for those of you who don't know, the Healthcare Authority is responsible for purchasing the benefits on behalf of both our Medicaid recipients as well as those who are covered by both the employees of the state of Washington and school district employees. So great to have everyone here. And we're also joined today by our colleagues at the National Opinion Research Center, or NORC, and Aurora Health Group. Really appreciate their support and assistance as we've prepared for this meeting and continuing to support this project. They're experts in value-based purchase payment models, stakeholder engagement, as well as communication, and again, assisting us with developing the model and gathering stakeholder input throughout the process. So because we're all now in a virtual environment, we still like to be able to create a sense of community and see that Beth and her colleague are already doing that. Wonderful to see. We'd like to invite everyone to go ahead and put your name and organization in the chat. We'd like to know who is able to make it today, as well as we want you to be able to see for yourselves who all is on the call with you. And I will note that this is our only time of using chat in the presentation. We anticipate using the Q&A functions moving forward for all of the, as we move forward. So please use that Q&A feature to submit feedback or questions on the presentation. Also, you will all be in listen only mode. And I think that Mia already put that the presentation is going to be available probably in a couple days on HCA's maternal care webpage, and the link there has been will be presented and provided to you at the end of the meeting. So next slide. And what we're hoping to cover today includes introducing the concept as well as the development of Washington's maternal care model. We're building on work that has been done by many of you already, I'm sure, so continuing to develop and refine that. We'll do something of a deep dive into the strategies used and lessons learned from other states. We'll be thinking about some of the key considerations we have for this model as we look at this from the perspective of what we will be thinking about in our Washington model. And then we'll go over a very high level project timeframe and have some time set aside to get your feedback and questions, and then provide you also sort of this continuation of where you can provide feedback and where you can provide feedback as well as get resources. And so if we could go to the next slide, which I will turn over to Beth.
Thanks, Mary. So just kind of starting us off here, we definitely wanted to be sure that we're sharing and explicit with what our goals are with this maternal care model. Like what is the change we want to see happen? Or you could also say, how will we know if we've done it, right? Like what are we going to really be looking to do? And at the highest level, it does really kind of come to increasing high value care. High value care is defined as better patient outcomes per dollar spent, right? So it's high quality, it's high value. And then these are some of the still large and broad, and we will get into a little bit more detail to have things for the group to react to. But these are really our top kind of 5 goals under that. What is high value? How are we going to get to high value care? So we do want to increase the utilization of and the quality of both prenatal and postpartum care. We absolutely want to reduce maternal mortality and morbidity. Our statistics and our data in this country are not good. I'm sure I'm not saying anything that anyone on this call probably doesn't know, right? The US is the only high income developed country that has a worsening trend of maternal mortality. We know what the drivers are for that. And so we want to commit to really changing that trajectory and explicitly address disparities in perinatal outcomes. Health equity is a goal. It's absolutely something that we can and should achieve eventually, and we will know when we've achieved health equity, right? Because we will have eliminated health disparities, and there are vast health disparities in the perinatal space. Some worsening, right? When we look at our populations, the folks who are really suffering are the furthest from optimal perinatal outcomes are folks who are Black and folks who are Native American, Indian, Alaska Native. Improve birth outcomes. So, again, depending on how you look at Washington metrics, to some degree, we look pretty good compared to some national metrics, and there's still room for improvement. I'm thinking of preterm birth, I'm thinking of low birth weight, I'm thinking of NICU admissions. Not all of these are preventable, but certainly there is space for us to lean in and improve on our birth outcomes. And then we really feel like it's important to increase care coordination. We repeatedly call this out as a gap. We hear this from you all, from our partners, from providers, those of us who have worked in care systems. We have very siloed care systems. We know that things can fall apart for people, for families during times of transition. So that can be from community services, from prenatal care to hospital or whatever delivery setting. It can be around discharge. It can certainly be later in the postpartum period. We are definitely thinking about difficulty with transition potentially now that we have 12 months of postpartum coverage, which is awesome and exciting, but how are we really supporting the work across those transitions, right? And how can we improve care coordination that will really have a dual generation impact, right? So both birth parents and also for infant. A little bit of background on the model. Washington State has long been really thinking about how we can improve prenatal delivery and postpartum care. The BRIE Collaborative absolutely leaned in on the subject over 2019 and 2020. Spent a lot of time and effort developing the BRIE maternity bundle. If folks aren't familiar with that, it's available, on the website. And so we are taking that product and we are kind of using it as our foundation and our baseline. And then we're just looking to further define it. A big piece of that work for us is layering on the financing model. That was not something that was like explicitly it was considered for sure, because I think the funding and dollars always come up, right? Financing is a powerful tool. We all know that, but it was just really the scope of the BRIE was really much more clinically focused. But we are absolutely taking that work and carrying it forward. Let me just see in my notes if there's anything else I wanted to say on this slide. Oh yeah, so a little bit about timeline here. So our plan is to further develop the maternity model over the course of this calendar year. And really the goal is by the end of 2022 calendar year, 2022, that we will have a model that is designed, not implemented, but designed. Okay, I think that's good. Next slide. So then digging in a little bit on the specific targets, like I think it's important to call out that really the purpose of a VBP or value-based purchasing model is really to drive provider behavior change and to some degree practice transformation, right? So looking at organizations and how things are done, but really many of the kind of the levers are really around provider change. And so when you think about then designing that model, we have what our goals are. We have to outline what are the behaviors that we actually want to change, right? That are going to, like you think about your whole logic model, right? Like this is the end game, this is what we want, and then how are we going to get there? And so these are kinds of all the work that we're really engaged in right now is really thinking about what are those behaviors that we really feel like are going to lead to the outcomes that we want. Again, right, that high value care, better patient outcomes per the dollar spent. And so when we're creating the maternal care model, we're considering how the model increases access and quality of prenatal and postpartum care. In our Medicaid population, for example, utilization of any postpartum visit is pretty low. It varies some by the MCO and by other factors, but if you look overall, it's around between like 50 and 60%. So again, when you think about opportunity for improvement, there's absolutely opportunity for improvement for increased utilization of that postpartum period. And now we have 12 months, right, of postpartum coverage. We plan to pay particular attention in our model to folks who have behavioral health needs. Again, this is informed both by data that we have on our population. A considerable amount of that is really looking at the maternal mortality review that's out of Department of Health, right? Where they really dive into pregnancy-associated and pregnancy-related deaths and behavioral health in that later postpartum period in particular is the #1 driver for those late pregnancy-related deaths. So again, I think then the question becomes, well, like, what are we going to do about that? And it's the big we, right? It's not just the HCA and it's not just providers, because we all need to be involved in this. This is a complicated system. It's a critically important time of life. And so the solutions are really going to require a lot of partnership and a lot of collaboration. So yeah, so definitely a focus on behavioral health needs. So what should that look like? I already mentioned coordination. That's definitely something we're talking about a lot, right? How can we do that? How can a model really incentivize and promote better coordination for pregnant, birthing, and postpartum people and their infants and their families, right? It's also, it's the dyad, and we think a lot about how we really need to talk more about the dyad, and it's also not just the dyad. There are other loving adults and partners and people that are really important too. Another thing that we really aim to do is team-based care. There is substantial evidence, both in terms of patient experience and satisfaction, and also just in terms of driving better outcomes, that team-based care is, where we need to move in terms of healthcare. So again, how can this model incorporate, incentivize, elevate team-based care with flexibility and tailoring to the individual patient and family? Like, what does that look like, and what are the different levers that we can pull in terms of the maternal care model? Doulas come up frequently in our conversation. There's active work in Washington. If folks aren't aware, there was a bill that passed, Senate House bill passed this past session, 1881, which is directing, it's both a policy and a funding bill, to set up a credential for doulas in Washington State by the Department of Health. So that's sort of on the trajectory to a Medicaid reimbursement. So there's exciting work happening and things are definitely moving forward. There's a lot of support, both in the governor's office and in the legislature for doulas. We at the HCA are also very supportive. We are well informed on the literature of doulas as a clearly an evidence-based strategy to improve birth outcomes, and particularly for people of color, which is something in terms of our goal around addressing disparities. When we see an intervention that has stronger effect sizes, good for everybody, seems to be good for everybody, but actually has stronger effect sizes for BIPOC. That is something we are keenly interested in, and how can we move forward with that intervention? I think, well, I didn't say anything about expanding the appropriate use of midwives. That is another goal for us at the Healthcare Authority. Currently, about 10% of our Medicaid births are midwifery driven. The way that that's sort of defined in our data is that, you know, the primary care provider during the pregnancy and postpartum period is a midwife. The vast majority of those remain hospital births. We do, if folks aren't aware, Medicaid does and has for quite some time paid for out of hospital or community birth. So that's both at birth centers and home births. Utilization is pretty low, and I'm not saying those options are what everybody wants. It is absolutely patient choice and preference. And we do think that some of the fairly low utilization, although higher than many other states, for midwifery-led care is that folks aren't aware of the option. And so then, well, whose role is that? Like, how can we, again, collaborate and partner on just giving people information that they need to make the best decision for them and their family? And I think there's good reason to think that if we can do that, that more folks will choose midwifery care. And again, if you look at the international landscape, huge differences between birth setting and birth provider in the US compared to other developed high income countries. And then I think when you, again, think about perinatal outcomes, you know, we have space to improve in terms of offering and supporting midwifery-led care to our Medicaid clients and families. Next slide, Mia. Or Tanya, sorry, I think Tanya's advancing the slides. So earlier I said we're gonna, this presentation, it's our kickoff, it's pretty high level, and we wanted to give you some things to think about that are on at least a little bit of a more detailed level. So again, here on the left, you will see, should be familiar to you by now, it was on the earlier slide. These are our highest level goals. And then when you see the goals in the middle, we've talked some about these, but so on the right are some examples of what we are actually thinking. None of this is, you know, signed off on in absolute terms. We are on the early stage of really finalizing and designing this model in terms of our work with our contracted partners. But these are things that we are talking about. These are interventions that we believe there's value in and that we are certainly considering and having as part of our model. We played around quite a bit with this graphic, and at one point had arrows going from certain interventions to certain goals, but we just came to the place like, that's confusing and it's not really representative of what we actually think is going to happen, because many of these interventions actually have a strong logical model that they could, right, that they could impact multiple goals. So that's how we got to, we're just going to list the examples and let the group read them and digest them and react to them. I've talked a little bit about postpartum care already, not only just increasing overall utilization, but how can we define the postpartum period in a way that's actually more aligned with people's recovery and experience as a new parent. In a way, it seems crazy that we ever thought one 6-week comprehensive visit check the box and that's postpartum care. So we definitely are looking at postpartum care differently than that, not only because we have 12 full months, but just in terms of what is the type of care that people may actually want and need. Telehealth comes into this conversation too, not only around postpartum care, but also antepartum. I've mentioned we really want to pay more attention to behavioral health, so you'll see that called out here. Increased physiologic birth, so our C-section rates in Washington overall, or if you look at low risk or NTSB, again, compared to some national statistics, we are, at least mid performers, and our C-section rates are too high. And there are, disparate outcomes in C-sections between race and ethnicity, none of which has a physiologic basis, right? And so we really want to address that. Midwives and doulas, I've already talked about a little bit. Chronic conditions. So we also, we know clearly, cardiovascular, certainly adverse cardiovascular events comes, top of mind. We also are, I think we're all aware of the changing demographics of pregnant people. Overall, pregnant people are older, which I'm old. I was pretty old when I had my daughter, and I'm a lot older now. And so chronic conditions in pregnant folks are something that, it's a reality, and we need to figure out how our care model can address chronic conditions more appropriately, more evidence-based. Social determinants of health is also something that we are definitely talking about. What does the care model look like in terms of how we can impact things that are stressing people? We know that social determinants of health also is a driver for health inequities and health disparities. So again, how I mentioned many of these interventions, if we can address them and target them, will have positive impacts across various goals. Reporting metrics. So anytime you're talking about a VBP model, reporting metrics are an important leg of that model. Can't measure and report on everything you would like to, so it has to be very thoughtful. Like, what are we going to choose? Like, what are the metrics that we think are actually going to drive better outcomes and meet our goals? We are just kind of starting to have, again, we have the debris and the work that was done. We need to do analytic work on our own Medicaid claims and encounters, and just really figure out, like, where's their variation, right? We're not going to pick metrics where it seems like overall we're performing high. That's great. We don't want to disincentivize anything that's already going well in the system. But we want to pick metrics where we feel like there's room for improvement, right? And it's really going to impact the health and well-being of our pregnant people and families. And then at the bottom there too, you'll just see, if you look at the evidence in terms of kind of what else in the perinatal space is really contributing to positive outcomes. You see group prenatal care, home visiting, medical home models. These all are, on our minds, on our lists in terms of the maternal care model, with some uncertainty of, how can the model incorporate these kind of other strategies or interventions, but just wanted the audience to be aware that we are also thinking of these additional interventions. And let me check my notes. I think that's good. Next slide, please, Tanya.
Great, thanks so much, Beth. And as you can see, a lot of our goals and then the levers we're thinking about are very closely tied to the discussions that were had at the BRIE Collaborative, and really, again, trying to think through, as we think about what are the best ways to achieve this high level goal, how do we really get there? And one of the things that we worked on initially was getting a better understanding of how other states have approached this work. So many states have thought about, how do we change either measurement or compensation related to the delivery of the these services, maternal services, in order to advance the outcomes that we're looking for. So NORC did a terrific job doing a very comprehensive scan across the states around what are those models that are being used in other Medicaid programs that Washington State can learn from. And we'll present here 3 basic models that we kind of gleaned and summarized from all that we looked at. The first is episodes of care, and you'll see this. Tennessee has a very robust episode of care system. They actually have, I think, about 49 episodes of care for different care delivery systems in their 10 care model, their Medicaid 10 care model. Colorado is another area that is looked also at developing an episode of care. And in this model, there is a quarterback or a single point responsible provider. This is not the payers. This is a provider that has been assigned the responsibility. They do an estimation of what the cost should be for the package of services they're asking for, and then they have risk sharing or a risk sharing threshold based upon those costs that can either be up and downside risk or upside only. They also, in these models, incorporate quality as a floor, if you will. So before any upside is shared, that the parameters set forth in a quality measure must be met. Or they may have incorporated, in addition to that, different pay for performance measures, like if you've done these different screenings, in addition to what the model says, we will give you an additional payment. And what they do is they limit on selected outcomes, quality outcomes, and things we typically see are things that we've already talked about, right? Which Beth talked about, the behavioral health screening and the necessity of that. A lot of work around substance use disorder. And because of the variety of different systems that are doing there is a lot of variety in the evaluation findings, and quality metrics and birth outcomes are both different in these, sort of across the states. But this is one kind of basic model that's focused both on cost as well as on quality, that sets a cost standard and then uses quality levers to achieve, again, higher quality at lower costs. The next model is a maternity or a pregnancy medical home model. So North Carolina has done this statewide, and they had a great sort of a 6.7 decrease in low birth weight babies from a study year of 2011 to 2014. And this is a care delivery model that looks to improving care coordination as well as the person-centered care through the delivering provider. So it is really about trying to wrap around care coordination to make sure that those things that are identified as important and that the patient is feeling a part of this journey in a different way than just with medical providers around them, somebody that they can relate to through this care coordination effort. And then sort of a riff on this strategy is showed here on the next slide, which is really an advancement of the health home model. So as we know, Washington State does have a health home model that we use. And this is looking at accomplishing many of the similar objectives to that pregnancy or maternity model, but focuses really on high cost, high need populations, and maybe because it links closely to the primary care provider, the provider that's going to give the continued care post-delivery, and it may be appropriate for an extended postpartum period. And when the health home models have been sort of studied in terms of outcomes for beneficiaries with chronic conditions, they found lots of great results. They have better quality of care, improved care coordination and management, better integration of primary care with the behavioral health providers. And as Beth talked about, we want to make sure that all of that care is being really intentionally aligned with the person who is providing care for the infant, for the parent, as well as the parent in whatever other comorbidities they may have. also, we have increased rates of transitional care and improved access to social services and community-based support. So the medical home model is just another a different manifestation of really trying to think about how do we get care coordination, how do we put measures out there around this specific service. So next slide. Great. And Beth, this is you.
Yeah, you would think I was so engaged with what you were saying, right? God, like, okay. So in developing this maternal care model, like we absolutely need and want feedback and input from you all, and I'm sure many folks who were unable to be here today. We have a pretty robust communication strategy that we will continue to execute. We also on a following slide.
I'm sorry, Beth, can I interrupt you for just a second? We're on slide 7, which is the key considerations for maternal model development. I think you may have gone to slide 12.
Oh, okay. No, I just was getting ahead of myself, Mary, but I just wanted to, yes. So this slide, we wanted to share with you key considerations, but I did want to highlight the importance for us in really hearing from our partners. We want to create a model that is centered on pregnant, birthing, and postpartum people, of course, and that works for providers and provider groups. We are actively engaged in learning from other states, what they have done around maternity episodes of care or other models, health homes, pregnancy medical homes, keenly interested in what things have gone well. You know, I think the reduction in low birth weight in North Carolina is obviously very impressive, and we want to talk to them, and we plan to, and kind of learn and hear more. We also really want to learn about things from other states. You know, sometimes people are less willing to share, but perhaps even more valuable, like when things don't work, you know, haven't gone well, when things didn't meet the goals, and what do we know about why that may have been the case. So, but we're not, you know, we're not the experts. I mean, we are committed to this work, and we feel like it's valuable and important, and this population needs better care and more attention. And we're not gonna, you know, get it right by ourselves. So these are just some of our considerations from the maternal care model. And we're hoping, you know, we're gonna have time today in Q&A, also just kind of, you know, setting some of the foundational groundwork in terms of hearing for folks, like how do we, how do folks feel about reward and risk sharing, shared accountability in any model, or about risk adjustment? Like, what are your thoughts? What are your ideas? We want to incentivize providers to participate. If we are going to create a model that we believe is going to drive better care, which is absolutely our goal and what we plan to do, then we want providers to participate because we want our clients to be receiving that model of care. And so how can we make that happen, right? Like what do folks see as the largest barriers or things that might get in the way? We know that in terms of, you know, connections between providers and increasing communication, that there are challenges here. We are not living in so much of a bubble that we don't realize that OB providers and pediatric providers oftentimes are not connected. They're not physically connected, right? They're not co-located. I mean, sometimes they are, but you know, and so, you know, we hear and I'm sure we'll continue to hear from providers, you know, that's too difficult. Like, how can we do that? And I would say, let's move together on trying to find solutions and what's reasonable. We do not want to create a model that is so burdensome that providers or provider groups or entities feel like they can't participate. And we also need to push a little bit, right? And not just end up back at the status quo because things feel too hard. So, and then we've talked about midwives, doulas, home visiting, and other evidence-based supports. Again, what do our partners and stakeholders and community folks working directly with families, like what are the opportunities here? What are the barriers? What are things that people are worried about?
Great. And that was my mistake. I'm so sorry, Beth. I was on the wrong slide. Apologies. I also was very engaged in, presenting on all those great things we learned from other states. And it is, really thinking about how are we building on the great work that already goes on in Washington? How do we just continue to work and improve on the care that's delivered and to get to a place where we can be very confident in meeting people where they are and providing them with the very best outcomes that our systems can deliver. So the timeline that we're looking at for this project, and alluded to it a little bit at the beginning of the presentation, is looking for this month and next to do these initial engagement sessions, as well as continuing to review the work that's been done in other states. Beth mentioned that we want to have more conversations. Yes, absolutely. We're looking for having a greater understanding. And I really like also that mantle of, it's great to hear about the successes, but we also as a community want to be learning from mistakes that have been made, so people can learn from the mistakes that we will inevitably make, but that we don't want to repeat things that they have found. And really our engagement is going to be very critical with you as the provider community and those interested parties. So looking forward to continuing these engagement sessions. August and September, we're going to start drafting some of the model design based upon both the environmental scan as well as input that's been shared and what we know about already. And then in October and November, we'll try to do some more engagement. We'll re-engage both with the tribes as well as with stakeholders with some of the draft ideas that we've developed. And this is important work. We don't want to design something that we bring up and then it doesn't work and so we walk away from it. We really want to make sure that we're doing something in a sustained way. And so that may mean that we take several steps iterative steps towards achieving the design. So we do hope in December to finalize design the model components and to create those implementation strategies. And then for next year, we're going to prepare for implementation, and if needed, we'll be asking for funding through our legislative process, and then we'll be looking to implement fully the maternity care model within our Medicaid program. And it could be that, this is it's sort of our best thinking at this time. It could be as we're smarter a week from now, a month from now, 2 months from now, that we look at this and think, yeah, maybe we can do some of the implementation within 2023. Maybe we can do some things within our Medicaid population that we see as glaringly obvious and something that we could do more in a near term. So maybe that's just a way of don't hold us accountable to this slide if we come to you mid-23 with something that we'd like to implement, because we will be thinking about that and want to be open to it, want to really be open to how do we best serve the people who are depending on us to create this the best system we can. So the next slide is really our question for you. Beth and I have been talking here for a while now, over half an hour, and want to hear any initial feedback on our key goals and the maternal care model. We have our Aurora colleagues who are monitoring the Q&A, so please, again, do not use the chat function, rather use the Q&A function, and Melissa will be sort of teeing up for us the questions and the feedback that you have. And again, sort of think broadly around what when you heard about those goals, what are your thoughts? What other considerations should we address as we're thinking about this model? Well, if you can imagine yourself, really excited in January of 2024 about finally we get the Washington version of a model, what do you think describes that most clearly? And what do you think you know, if I were to say to you, yep, we have the model, everything worked great, you think, oh boy, that means they must have addressed this. So this is your chance to be telling us, informing us around what input should we be thinking about as we begin this important journey together.
Thanks, Mary. Hi, everyone. My name is Melissa Cohen with Aurora Health Group, and I will be posing the questions to Mary and Beth that appear in the Q&A, not the chat. And we'll take back any questions that we don't have time for, as well as those that we don't have an answer for live. So first question to Mary and Beth. How does First Steps and MSS fit in this work with the maternal care model?
You want me to start, Mary?
Sure.
Sure. That's a great question. First Steps, or MSS and ICM, are in scope for this project, meaning we have called out those programs. The folks at the HCA who work most directly with those programs are involved in the project team. Definitely come up around the home visiting conversation, and like, how do MSS and ICM fit into the broader maternal care model? Specifics around, will MSS and ICM like evolve in terms of programmatically or focus area or units? Like, I'm sure MSS and ICM providers that are with us today, are wondering about. I think all of those things are possible, and we don't yet know the answer on those. But MSS and ICM are definitely part of this conversation, because if we're talking about a system of care, they have to be, right? So I'm sorry, I don't have more specifics, but we just don't have them yet around MSS and ICM.
Yeah, I would just add, that's a great answer, Beth. I would just add that it reminds me of Mary Ann Lindenblad. And of course, we all remember Mary Ann is our Medicaid director for several years. And she was really clear about, let's look at and try to build on things that are working currently. And so as we think about designing the model, as you know, many of the goals talk about how do we create that better coordination. And in that, MSS helps that, and we have an established process for that. We really want to build on what's working. If we see there are opportunities or ways that as we look at the next design, there are ways to streamline and simplify by changing things, we hope the community will be open to that we want to make sure that we're not just, because we've had a specific model for many years, that we're going to be open to looking at that carefully and thinking about the measures that we're wanting and potentially then changing some of the components of it and as we move forward.
Thank you both. Next question. Is this model dependent upon receiving state funding in 2023?
So I can start with that, Beth, and then you can either correct or add on. So we don't know is the short answer, right? What we do know is that there is a very long process, right, for putting forward requests from an agency level and then having that embedded into the budget documents that start with the governor's budget release in around November each year. The governor will come on and release his or her budget. And at this point, we're in the process of developing our what we call concept papers that evolve into decision papers, because there are a lot of great ideas being generated around how we improve the delivery system. And when we are more mature with our design, which is really important for us to be thinking about and working towards those design elements, then we'll know better if there is a request that we need to make from the authorizing environment to do any specific funding around that. And then we would work through that process, and we would be in that process, and then we may need to change things based upon the funding that's received. So just to complete that cycle, so nobody has sort of a question in their mind, the governor releases their budget in before session starts, and then the legislature comes to town, they discuss the budget and all of its components, then they pass a budget by the end of session, and that is, typically in the April or May timeframe, based upon whether it's a long or a short session, and then that budget becomes implemented in July of the following year, and then there's a supplemental budget. It's a 2-year budget, and every other year it's a short cycle, and so it's just a supplemental to add to the requests that are already in there. But that is the process. And having come out of the healthcare industry into state government, it still surprises me how long it takes, but that is that's the trajectory that we're on. And sometimes things, different things can happen and things can go faster, but that's the typical cycle.
Yeah, I would, I'm glad you answered that, Mary. That was, you did a much better job. And I would the only thing just to add on is, and hopefully this was clear for what we've talked about, like our primary goals are really around improving population health, perinatal outcomes, and addressing racial and ethnic disparities. That is different from some other VBP or maternity episode of care work that we're aware of and we're learning from, and it's important, done in other states where the clear primary objective was cost reduction. That is not how we are framing up this work. We want to get more out of what we are spending, right? I mean, we want better care, more coordinated systems, but ultimately better family level health. And that is really our priority, and that is what we talk about.
Thank you both. Next question asks a bit about the stakeholder process. Is there space for community-based stakeholders at this stage of the work? And how will they know about this work prior to the design phase of the model?
So yes, I think there's absolutely a role and a need for community-based providers. I'm sorry, now I forget if you phrased it, community-based organizations, but we have launched, and we're going to have this on our last slide. We have launched a website on the HCA broad website, but there's a maternal model website. This recording is going to be there shortly. It's also where we're going to post other updates. There is a function on that website for folks to email us. We have developed a system on our end for tracking and monitoring those questions and responding to them. So we are hoping for as much input, and we say this now. We've sort of had conversations about how much are we gonna, how much of someone's time is it going to be taking? But at this point, we're just going with more, the more the better. Like, we want to hear from people. So hopefully that answered your question and is at least one avenue for giving us ongoing feedback.
Thanks, Beth. Next question is about community-based midwives. Many hospitals and hospital-based providers still hold bias against licensed midwives. So how do you see getting that collaboration going? Autonomy, second question from this poster, autonomy as providers is really important. Would working within this model require care providers to follow or answer to certain standards or protocols, and who would set those? So that's a two-part question.
Okay. So the first question, I'm so sorry. Well, the first question was community-based midwives and
getting that collaboration, as the commenter noted that hospital-based providers may hold some bias.
I totally agree. That is an issue and something that community-based midwives experience. Hard to know if this, honestly, I think I'm just gonna elevate it because I think it's important. There are a lot of gaps in our systems of care. I think bias and mistrust of community-based midwives is absolutely one. Is this model going to, or could it possibly address, right? Like, is it going to be the silver bullet I mean, can it? Like, is that a reasonable goal? And I think the answer to that is no. I do hope that through this work and hopefully connecting more with people, that we develop other strategies and collaborations around, how do we address other issues in our system of care that are really negatively impacting our patients and families and providers, I mean, to be fair. But I don't necessarily see a lever in the maternal care model under a VBP structure to address mistrust and kind of anti-bias against community midwives. That doesn't mean that that's not an issue that needs to be addressed, but I'm just not clear that this model really is going to have an opportunity to do that directly. We are engaged in a national midwifery collaborative where we are talking about that as one of many contributing factors to perhaps low utilization of midwives in Washington. That's a separate project, but it's related, and I'd be happy to talk to whoever that was more about that project. Oh, and then the second question. Sorry, Melissa, can you read the second question again?
The second question was around whether the model will involve protocols in care and who would set those.
So clinical care components will, I say this so definitively, and then we say we're early in the project. I believe, yes, that there will be clinical care standards and components and requirements in the model, but it sounded like your question was more kind of about a reporting structure. That sounded more like a licensure scope of practice issue, and the model will not be addressing like any licensure or scope of practice or credentialing or those kinds of issues.
My next question actually combines a number of different commenters so that we can hit out a few of these. It asks about whether lactation, the role of fathers, or peer-to-peer supports will have a role in this model. So those are three separate questions that I've combined.
Okay, lactation. We talk about lactation. We know that there's gaps in lactation breastfeeding support to our clients. A current issue or barrier in Washington in terms of Medicaid is that lactation IBCLCs are not a Medicaid approved provider type in Washington. That doesn't mean that couldn't happen. Idaho fairly recently added, was like, whoa, look at Idaho. I think it's not too often. Okay, I'm not going to comment on that. So Idaho has done this. It was absolutely driven by IBCLCs who went to the legislature and ultimately got a credential for, it's similar sort of to what is happening here now in Washington with doulas. The doula legislation was very much doula led. So lactation consultants did that in Idaho and were successful. I think this maternal care model, like that is out of scope in terms of, is part of this project going to be moving towards like, credentialing for IBCLCs? That's just not within the scope, but are we talking about, have we brought up in our meetings and conversations, like what about lactation support? What do we know are the gaps in the system? MSS comes up in that conversation as well as other home visiting programs. But I don't see a direct kind of mechanism again via this model to change payment to IBCLCs. And I guess I'm sort of guessing that was maybe more of your question. That's sort of a separate path.
Okay. And the other two questions around elements of this model were peer-to-peer supports and engagement of fathers.
Yeah. So fathers, partners, diverse families, again, we talk about that. If you really center the pregnant, birthing, postpartum person, critically important that you're looking at their system and their support system and their natural supports. It comes up when we talk about things like group models of prenatal care, which can and often do incorporate, but don't have to. Partners, partners, fathers, husbands, grandpa, whatever, loving adults that are a natural support to people. So that's one space where we're definitely talking about. I hear that fathers was asked specifically, so I'm framing it a little broader. How else are we talking about other family and support people? I mean, it's a little tricky because we are a payer. And so a lot of our model thinking and creation is, I mean, just to be frank, like is around the pregnant person or the infant, right? Because those are the folks that we are directly responsible for. But I don't think that we are closing our eyes to how important and how we can elevate supporting family and loving structures more broadly, because ultimately that's critically important to the dyad. Peer supports. Yes, there's a lot kind of circulating in Medicaid more broadly around peer support. So both in terms of behavioral health peer supports, in terms of community health workers, there's a lot happening in the community health worker space. So in terms of this project, I would say we talk about peer support when we're thinking about team-based care. Right, so if we truly want to develop a model that allows more flexibility, more ability to tailor services to individuals, and that team-based care and multidisciplinary teams need to be part of that. What are our options, right? What have other states done? What can that look like? What if there were, community health workers who were, are specially trained in terms of the perinatal space? And as I say that, my MSS ICM colleagues are probably yelling at me inside their own Zoom and saying, we have that in MSS, and we do. So CHWs are part of the MSS team, but is there a more broad, robust way to really look at peer support? Again, I would circle back to when you look at the evidence, peer support in terms of improving population health outcomes and also addressing disparities. We know that peer support is going to be a front runner, and doulas, I would say, fall under peer support broadly too. I hope doulas would agree with that. I think they would.
Mary and Beth, thank you so much. We only have a couple of minutes left. So any other questions that we did not get to, we will take back so that Mary and Beth have a chance to look over and provide feedback. And now I will pass it over to you, Beth and Mary, to close us out.
Great, and I think, Beth, do you want to run through these last couple slides here?
Yeah, sure thing. So again, this was the kickoff webinar. We are proceeding with, our communications and stakeholder engagement process. We plan to have other engagement sessions. Mary already mentioned our tribal partners. We have government to government relationships with our tribal partners. And so we are doing kind of a separate, although our tribal partners are always invited to anything, but we do sort of have a separate process in terms of engaging with our tribal partners. That is the inbox. The mailbox, the HCA Maternal Care Model, again, that we have set up an internal process to monitor those comments. I think what we do with them and how we circle that information back remains to be seen, because we really have no idea how much we're going to get and what it's going to look like. We've thrown out will we be doing FAQs? So just say we're going to figure it out, what makes sense. But you can certainly send any input or questions to us at that mailbox. And then the last bullet here is the HCA website. Oh, sorry, and then it's also on the next page. You can go to the next one. So that is the HCA website. I mentioned already the webinar slides and recording will be posted there. We're hoping it's Tuesday, right? By the end of the week, I think they'll be posted there. There's some broad overview messaging, hopefully all things that align with what you heard today. I certainly believe that that's true. That's on that webpage. The inbox is also on that webpage. So if you didn't note it, that's no problem. If you want to bookmark the website, then you will always have access to it. And it is 11:29. So we thank you so much for being here and for your super thoughtful, difficult questions, which is what we were hoping for. And we hope that you continue to stay engaged with us on this really important work.
Yes, thank you so much. Appreciate your time and attention today, and look forward to continuing this work with you. So bye-bye, everyone.